Welcome everybody, and I'd like to welcome you to the first journal club that Tactile is putting together on venous and lymphatic disease. Honored to have my co-moderators here, or co-speakers, Dr. Tom O'Donnell and Steve Dean, and we have three interesting papers that we're going to be discussing during this call on venous and lymphatic disease and phlebital lymphedema. And I'm sure everybody dreads the days of having journal club and preparing and reading the papers and having to be ready to be called on. Here, this is not going to be the situation. Hopefully you guys, everybody read the papers that were sent out and be kind of almost ready to ask us questions. We're going to sit and analyze the papers and provide our criticisms, and I'm sure my colleagues here are going to criticize each other as well as myself. I'd like to start off by kind of launching a poll question to everybody. When is the last time you attended a journal club? Yeah, the usual situation is, at least even these days, the residents or the fellows come in and they're reading the paper in the elevator as they're getting ready to make it to journal club. Usually the only reason they show up is because of the food. Unfortunately, we don't have any food, and I just got yelled at for drinking a glass of wine. So 33%, I'm a journal club newbie. Okay, and kind of split across every other category there. So here are the results for you, so you can see them. And I think we can get started. Our first speaker is going to be Steve Dean, and Steve's going to be presenting a paper of his on the clinical characteristics of lower extremity lymphedema. Steve, go ahead.
Okay, let's try and get this share screen to function. All right, thank you for that introduction. Welcome, everybody. As you can see here, our presentation is going to be on a paper that was published electronically earlier this year in JVS, the clinical characteristics of lower extremity lymphedema in 440 patients. And to start out, we've got to go through a few questions. I would ask you to identify the cause of limb swelling in this individual. Is this consistent with lipedema, of vascular malformation, pretibial myxedema, or phlebital lymphedema? Tony, I think, or Dr. Gasparis is in charge of the voting here. Oh my. Okay. Well done. Yeah, not much to say. You identified the constellation of stasis changes and a modest amount of foot swelling. Pretty classic case of phlebital lymphedema. So we'll make it a little bit tougher. What is the cause of this patient's swelling? Is it phlebital lymphedema, lipolymphedema, lympholipedema, or lipophlebal lymphedema? Outstanding. Majority got this correct at lipophlebal lymphedema. This is clearly a multifactorial lymphedema. First of all, I just love to point out, look at this dramatic truncal lower extremity mismatch, a characteristic of lipedema. I mean, that waist is not that big in proportion to the limbs. Again, suggests that lipedema is the predominant problem here. But you see the stasis changes, a little bit of foot swelling consistent with phlebital lymphedema, and there's even some massive localized lymphedema. So that's clearly a multifactorial lymphedema. Things aren't always straightforward and only due to one cause. All right, so let's go on to the presentation. From a methodologic standpoint, this was a 3-year retrospective analysis of the characteristics of 440 eligible patients with lower extremity lymphedema who presented for lymphatic physiotherapy to a University Medical Center's cancer-based physical therapy department. And note that I emphasize cancer-based. And that's to emphasize the point that I think there really was inherent referral biases in this population. And this is evident by, here's the cancer-associated or physical therapy center. You can see the word cancer is predominantly displayed. They're catering to the cancer population. And for reasons that I just quite don't understand, I've never seen them advertise, we love taking care of morbidly obese febrile lymphedema patients. So just keeping that in mind, that there really is inherent referral bias, I think, in this study. All right, so what were the results? Well, the four most common causes of lymphedema were: number one, chronic venous insufficiency at 42%, despite that inherent referral bias. Number two was cancer-related therapy. Number three, primary lymphedema. Number four, lipedema at 12%. And just briefly, here's one of the 42% of the patients that had febrile lymphedema. Obviously, everybody recognizes this. The only thing I want to point out here is in most cases of febrile lymphedema, the feet and the toes are just modestly swollen at best. Sometimes they're never swollen. So here's a demographic table. Let's just get right in and talk about gender. There was a distinct female gender proclivity in this population, like most populations of lymphedema, about 70%. And that was the case in 3 out of 4 of these groups, with the exception of the phlebo-lymphedema group, where the males and females were roughly equally represented. And then on to ethnicity, this population was predominantly white. About 8 out of 10 patients were white, and this was the case in 3 out of the 4 subgroups. But it was interesting, with the exception of the primary lymphedema group, or the primary lymphedema group, there was an unusual disproportionate amount of the Black population represented in primary lymphedema at 42%. That really stood out, and that is a novel finding. And just to contrast the dorsal feet and the phlebo-lymphedema patient with the primary lymphedema patient, look at the marked foot swelling, a distinct difference between the two. And again, just emphasizing, like this patient, the Black population was disproportionately represented for unclear reasons. So let's look at the limb distribution. 75% of these cases had bilateral lymphedema. And that was the case in all of these groups, with the exception of the cancer-related lymphedema group, where the unilateral and bilateral groups were roughly equally represented. And then we looked at what was more likely to be swollen, the left or the right limbs. And if you look at the bilateral population, you can see that in about bilateral limb swelling, about 70% of the time, the left leg was statistically highly more likely to be swollen than the right leg.
So Steve, go back for a second.
Yeah.
Just one more. So in the CVI febrile lymphedema, 90%, right?
Mm-hmm.
Had bilateral.
Were bilateral, exactly. And as you would expect, in the lipedema group, 100% were bilateral, just by definition. That's disease. Now,
one of the attendees is asking, so do you, if you have a patient with, you suspect has lymphedema, you're not sure it's febrile lymphedema, would you recommend getting a venous ultrasound on them routinely?
I'd say, yeah, definitely routinely. Almost anybody that comes into my clinic with limb swelling is going to get a venous ultrasound.
But for reflux?
Well, for reflux, yeah, sure. For reflux, for obstruction, standard reasons.
All right. Tom, do you routinely do that too?
Just wanted to, yes. I look at duplex ultrasound as a vascular surgeon's stethoscope.
Mm-hmm.
We can't wear it around our neck like most of the trendy internists, but it is the go-to evaluation, because it shows not only the venous disease, but it also will give you hints as far as the potential for lymphedema.
Yeah, I mean, we actually see, actually the three of us and a few others that recently published, just became available on JVS, on diagnostic algorithm in patients with leg swelling. And part of the algorithm is a nice flow chart, is basically showing that these patients should be routinely getting an ultrasound, looking for both superficial disease as well as deep venous disease.
Absolutely, Dr. Gasparis. All right, well, let's go on. And
very formal, Steve,
Okay, so let's go on to the unilateral lymphedema group. So what was more likely to be involved, the left or the right leg? And again, it was the left leg about 6 out of 10 times. And it didn't quite reach statistical significance at 0.058, but it was really close. And then we specifically looked at the subgroup of the phlebolymphedema population. Only 75% of the patients with unilateral phlebolymphedema was more likely to involve the left side. So clearly all these cases are more likely to be left side.
Why is
Let's talk, what's that?
Why do you think?
I would think the obvious reason, and also based on some of the weight data with the bilateral LE, is it's related to left iliac vein compression.
Mm-hmm.
I don't know how else to explain that. So let's talk about the weight. This was a rather large population. Now, keep in mind, I live in Ohio. We're using the top 15 of obesity. And the mean BMI was fulfilled the definition of morbid obesity. This was the mean BMI at 40.2. And then we found that the weight significantly correlated with the higher ISL lymphedema stage. That's not surprising, it just hadn't been published before. For instance, in the stage 3 group, the mean BMI was a whopping 57, consistent with super obesity, and it was 37.5 in the stage 2 group. And let's look at some of the intergroup comparisons. Like I said, overall, we'll look at the mean BMI here, which is encircled in red at 40.2. There is a statistically significant lower difference, not surprisingly, in the cancer-related lymphedema group at only 30. But yet even that I find is remarkable. Is here you have a cancer population that just fulfills the definition of obesity at 30. And then in the other groups, you can see here, phlebolymphedema was 46, lipolymphedema, it was 48 and 41 in the primary lymphedema group. What about stage 1 versus stage 2 versus stage 3? A very distinct minority, only about 1.5% actually had stage 1 lymphedema, and these were exclusively represented in the lipolymphedema group. The clear preponderance at 85% were stage 2, and then we had about 14% of stage 3 lymphedemas fulfilling the definition of elephantiasis. And note that, not surprising, we didn't have any stage 3 or elephantiasic patients in the cancer-related lymphedema group. So what about cellulitis? Well, approximately 1 in 3, that was 36% of the population, sustained 1 or more episodes of cellulitis. But an interesting finding was patients with stage 3 lymphedema had roughly twice the rate of cellulitis as patients with stage 2. It was 62% versus 32% respectively. And then we looked at cellulitis in the 4 groups and compared it. Well, cellulitis was significantly more likely to complicate patients with either phlebolymphedema, lipolymphedema, or primary lymphedema about 50% of the time than patients with cancer-related lymphedema, where it was only 13% of the time, and obviously a highly statistically significant difference between those populations. Multifactorial lymphedema, that is 2 or more causes of lymphedema existed in 1 in 4 of the patients. And approximately half of the patients with lipedema with secondary lymphedema or primary lymphedema had a superimposed cause of their swelling. And it was usually chronic venous insufficiency. And here's a highly illustrative example of a patient with longstanding lipedema, as you can see. Those are obviously fatty legs, you see an ankle cuff sign, but you also see the venous stasis hyperpigmentation and just a minimal amount of foot swelling. So that was pretty common actually in the lipedema group. And that's a novel finding. I don't think it's a novel finding, but it's the first time it's been published.
Now, Steve, go back to that picture.
Yes.
Now, you know, how can you tell from this picture, just for the audience education, I guess, how can you tell from this picture that the patient has reflux or deep venous or superficial venous disease compared to like pigmentation secondary to obesity, venous hypertension?
Yeah, well, you couldn't tell without an ultrasound.
Well, I mean, one thing, I think the fact that it's unilateral, kind of, you would expect if it was obesity related.
I'll just say it's worse. Ooh, let me go. I'm sorry, Tony. Here, you can see here there are some changes on that left leg too, just not as severe.
Yeah. But usually, I see when they're obese and they have venous related legs, they're usually pretty symmetrical.
Okay, I see where you want this. Well, that's an excellent point. That's a very, very good point. Yeah, and I think, again, this is not an uncommon finding for us to see a lot of lymphedema patients. It's just that good luck finding that in the literature. So that's what I thought was interesting about it. It was in 1/2 of our lymphedema patients. And again, with the mean BMI of 48, to underscore your point, Dr. Tony. All right, and so finally, this is a table just showing this concept of multifactorial lymphedema that occurred in 1 in 4 patients. We're not going to go through all these, but just to show you, for instance, you could stand, and the first diagnosis listed is the principal diagnosis of their lymphedema, and then the second one is the adjunctive cause. So you had a population of patients that had cancer-related lymphedema, but they subsequently developed chronic venous insufficiency, and these were all either DVTs or iliac vein stenosis. The lymphedema group. Here's lymphedema with CVI. We talked about that. You could add in CVI in cancer therapy. And same for the primary lymphedema group. A lot of different iterations here. Primary lymphedema ultimately develops chronic venous insufficiency, which I see a lot, and surgery. And here's a great example. This was a patient that had long-standing primary lymphedema that over the last several years started to eventuate in secondary lymphedema. So it can definitely happen. And note the marked foot swelling, which gives you a clue that this patient's predominant cause of their swelling is primary lymphedema. It's not phlebolymphodema. That's not the biggest cause here. Shouldn't see feet swelling like that. And then finally, we also looked at worsening of pre-existing lymphedema in one of these 4 groups by a superimposed non-cancer surgery. Total knee replacement arthroplasty was the dominant cause of this. And again, I think we all see this in our practice, but yet it's not published in the literature. So I thought that's what was fulfilling about this data, was the fact that we did identify about 6 out of 10 times it was total knee replacement arthroplasty that worsened their pre-existing lymphedema. And there's a great example right there.
Well, the other thing is these patients, you know, you may find underlying venous, and they had no venous disease, these patients.
Oh, they certainly could have, yeah. Yeah, they could have been one of the 4 groups, the phlebolymphodema group. They undergo a subsequent knee replacement arthroplasty and their swelling gets worse. So that's what we were looking for, is a history of worsening on the side of the knee replacement arthro, or whatever the trauma was. But in this case,
some of these patients will have an asymptomatic DVT, which may also be contributing.
Absolutely.
The other point about the total knee arthroplasty, if you look at the Medicare database, it is actually more frequent than total hip arthroplasty. So your population at risk is huge, disproportionate to the other surgical procedures you mentioned here. So it's
that comment's borne out in the table. That's for sure, Tom. So excellent point. Number 2, just out of interest, was actually a severe trauma with associated surgery, and they had to undergo surgery. And I would point out here a great saphenous vein harvesting and even foot surgery were tied for the 3rd most common causes. So let's wrap this up. I think the take-home message is that chronic venous insufficiency, not cancer-related therapy, I put in here may be the dominant cause of lower extremity secondary lymphedema. I think it is, but we'll say maybe until more data becomes available. The patients were predominantly female, white. They had bilateral leg swelling in 3 out of 4 cases. The left leg was preferentially involved. Cellulitis occurred about 1 in 3, but it was about 50% in the non-cancer related groups. And again, remember that low percentage of patients with cancer-related cellulitis. Talked about total knee replacement arthroplasty, and again, this concept of multifactorial lymphedema, which is real life. It's just not typically published in any data or papers that I'm aware of. And I'll leave there and stop sharing.
Thanks, Steve. A couple of questions for you. One, first is a comment that if a patient has lymphedema as a diagnosis, that some insurance companies deny payment for a venous duplex ultrasound. Therefore, he never lists this as a diagnosis. I'm not sure that's the right way of approaching this.
Yeah, I agree. I would put limb swelling down there too.
Swelling.
Yeah.
What's your definition of cellulitis? Strict definition of cellulitis. the comment is that many primary care physicians often will see, the acute changes or that occur in somebody that's advancing to like C4 disease and they get erythema or whatever. And it's more of, inflammation than infection. And they get diagnosed with an infection or cellulitis and put on antibiotics. How do you tell when these patients who have concomitant CVI that it's not
a stasis cellulitis or a stasis dermatitis? Yeah, that's a great question. I tell you, probably the one thing that helps you out more than anything is it bilateral or unilateral. You always got to be suspicious if somebody comes in with bilateral inflammation that's probably stasis, not infection, because true infectious bilateral cellulitis is relatively rare. So that's number one. I would say chronicity, if there's chronicity involved, I'd be more suspicious at stasis versus if just happens acutely, that suggested it's bacterial. I'd look for skip areas that are very characteristic. And of course, if you have systemic manifestations, there's your answer that it's bacterial in origin, not stasis. But I really hone in on the bilaterality, because that's where I often see that misdiagnosis for stasis versus bacterial.
Staying on the infection situation, how many of these patients with cellulitis actually were hospitalized for treatment?
Oh, Tom, I can't tell you based on this was a retrospective review, and it wasn't designed to go in and look at that. It was just looking for a history of.
Well, can you tell me from the phlebital lymphedema, which is the most frequent, how many was C6 versus C5, or you don't have that data?
Yeah, we have that data. This was an advanced C population. Only 20% were C3, 80% were either C4 or C5, C6, and it was roughly split between the two. So it was a 40-40 split, to answer your question.
But was it more common in the cellulitis episodes in the C6 with an open lesion?
Oh, I see what you're saying. No, I don't have that data no, I'm sorry.
A comment or a question on the impact of abdominal venous hypertension on obesity related to CVI. Tom, you want to take a stab at that?
Right. The increased intra-abdominal pressure translates into an increased venous pressure. And there's actually been studies that have shown treatment of the obesity surgically is associated with a reduction of venous pressure. So it compounds any pre-existing venous insufficiency, but in itself can cause problems with venous hypertension, just obesity itself.
Mm-hmm.
Yeah,
and actually there have been some, even with IVUS, you can see the IVC is pretty small in these patients sometimes.
Yeah, I encourage you to look at the papers by Willenberg. They've looked at very elegant studies of the hemodynamics of the common femoral veins in the obese population. Surprisingly, it doesn't take much weight to inhibit the venous flow.
Steve, someone's asking, what's your definition of primary lymphedema?
Of primary?
Yeah.
I think it's classic lymphedema without a secondary cause. And as far as, I would just leave it at that. I mean, if you have somebody in a suggestive environment, I mean, you've got a young female that develops unilateral lymphedema in their adolescent years, your suspicion is very high. But yeah, there's no obvious secondary cause.
Now, someone's asking about ablation of the saphenous vein in these patients. I think, in general, depends on what the predominant cause. I think the picture Steve showed of the patient with a classic lymphedema leg who has, concomitant venous insufficiency, that patient, I'm not sure you're going to make them a whole lot better versus somebody who has phlebital lymphedema that's just progressing over time. And even in that situation, when you look at the literature with venous interventions, only looking at swelling itself, because of the long-standing venous hypertension, you've damaged the lymphatic side. And then even if you treat the venous hypertension, they don't necessarily resolve their leg swelling.
You're exactly right. The late Robert Linton, with whom I had some interaction was at the Mass General, always said, never promise a patient with varicose veins and swelling that you'll get rid of their swelling with surgery.
And there are some situations, I've had a couple of patients that actually who had mostly lymphedema as their primary problem and had a venous ablation and ended up getting worse.
Oh, absolutely, Tony. Yeah, they see a lot. Those patients aren't very happy for some reason.
That's because the superficial lymphatics run along the great saphenous vein, and the thermal injury causes lymphatic dysfunction.
Absolutely. Ventromedial lymphatic bundle, yeah.
Well, I'm going to leave the rest of these questions. We'll answer maybe at the end, just so we can move along to our next speaker, who's Dr. O'Donnell. And he's going to review a paper on systematic review on guidelines for lymphedema. And he's actually one of the authors. And he's going to give us this review of that paper.
Thank you, Tony. Just go to slideshow. Well, it's fun to talk to all of you. I can tell you when I was attending or working with some of our residents, most of them would be asleep because we did our journal club in the morning, and here we are at night, and some of you may be asleep already. But what I'd like to talk about is a paper that's in the July issue of the Journal of Vascular Surgery, Venous Lymphatic Disease, on systematic review of guidelines for lymphedema. Now, we're all familiar with clinical practice guidelines, and we use the abbreviation CPGs. In the Institute of Medicine's revised definition in 2011, they characterized them as recommendations intended to optimize patient care that are informed by a systematic review of evidence. That phrase is new from the original definition, as well as balancing the benefits and harms of alternative care options. It's important to know that a clinical practice guideline is not a clinical consensus statement, which reflects opinions usually synthesized from an organized group of experts into a written document, but does not have a formal evidence review to support it. And in contrast to a position paper, which presents an opinion about an issue, usually that of the author or another specified entity such as a medical society. So what is the value of a guideline? And most of you are familiar with the SBS AVF guidelines and others. It provides consistency among treatment protocols given to patients. It's not cookbook medicine, but it's to provide some consistency. And the efficacy and quality of care is usually improved by following guidelines. And as a result, medical resource use and the cost of providing that care is usually reduced. It's very important to realize that insurance companies focus on guidelines for their justification for allowing or denying treatment. And a great example is the impact of the varicose vein guidelines on the ability to perform venous ablation surgery. And this is typical of the SBS AVF guidelines. This is one that I and Mark Passman edited, published back in 2014. As far as lymphedema guidelines, what we did in this paper was to look at the diagnosis, outcome measures, treatment types, conservative pneumatic compression and surgery, and look at the content within these guidelines. We performed a systematic review of the available literature on lymphedema guidelines. And a systematic review really attempts to collate all empirical evidence that fits pre-specified eligibility criteria in order to answer a specific research question. And for us, that in this particular paper was, what's the breadth of content for these guidelines? What is the literature supporting that? Is it contemporary? And what is the methodologic strength of a particular guideline? This is a prisma diagram that shows from various sources, we identified 245 potential articles that might be guidelines. On those, we performed what we call horizon scan, or looked at the abstract. That distilled it to 13, and those underwent a full review. And you can see we eliminated on your right position statements, systematic reviews. On your left, limited scope or focusing only on breast cancer. So we ended up with 4 actual clinical practice guidelines for lymphedema in this review. The first was best practice for management of lymphedema, published in 2006. The next was CREST, which is, as opposed to the previous, which was a society. This is published by the government of Northern Ireland, published in February 2008. And then a Japanese practice guideline for the management of lymphedema, published in 2011. And then the Handbook of Venous and Lymphatic Disorders, which within the content of these chapters had guidelines. And Dr. Dean, one of our speakers, wrote a very good chapter in this. The basic characteristics of those 4 were that 3 of the 4 were published before or at 2011. And most importantly, the last reference date in 3 of those 4 guidelines was 2007. So you can see right away there's a problem of contemporary relevance of the evidence they gathered. As far as methodology, 2 of the 4 only performed a systematic review rather than all 4. And the strength of recommendation was cited in only 2 of the 4. By contrast, 3 of the 4 talked about the quality of evidence they used to support the guideline. So this points at fairly weak methodology. As far as diagnostic modalities, the majority mentioned clinical. Decidedly absent was there was no discussion of diagnosis in the Japanese guidelines. Duplex ultrasound was recommended in 2 of the 3. CT MRI was used not to characterize the lymphatics, but to rule out, particularly in secondary lymphedema, a neoplasm. The overall test of choice, remember these are old guidelines, was lymphoscintigraphy. And the type of staging was different in all 3. ISL was used for the lymphedema, and CREST used primary and secondary, but no typical International Society of Lymphology staging.
Tom.
Yeah.
So in the use of ultrasound for diagnosis, is that for just using ultrasound in these patient population or for the diagnosis of lymphedema?
It's for both. It's to rule in or rule out a venous component, i.e. for phlebolymphedema, and then you can image the skin and the subcutaneous tissue for characteristic changes that one can see with lymphedema.
So it's mind-boggling to me that AVF didn't have ultrasound as part of their recommendation in the guideline.
Oh, they didn't, not specifically for diagnosing lymphedema.
Yeah.
Right. Now this sort of summarized what type of conservative treatment was given. CDT was recommended in 3 out of 4. The Japanese guideline didn't. Manual lymphatic drainage, all 4, but with various levels. The highest was the American Venous Forum. Some form of compression, multi-layer bandage, or compression garments were also recommended in 4 out of 4, again with varying levels of confidence. By contrast, when you come to pneumatic compression, the older lymphedema guidelines said, although there's considerable international debate over its effectiveness, pneumatic compression is widely used and it may form part of intensive therapy, a long-term management of selected patients. The Northern Ireland guideline didn't even discuss pneumatic compression. The Japanese guideline gave a low recommendation, D on a scale of A to E. But due to the dates of the literature searches in these three guidelines, none of the few recent randomized controlled trials for pneumatic compression are cited. By contrast, the American Venous Forum guidelines published in 2017 stated that to reduce lymphedema, we suggest compression pumps in some patients with a 2B recommendation. What they failed to cite was an important randomized controlled trial done by Caroline Fife. And this shows the results of measurements of edema volume by circumferential measurements comparing an advanced pneumatic compression device, EO652, to a simple pneumatic compression device. And you can see there's a statistically significant reduction in edema volume versus the EO651. Similarly, looking at local tissue water, improvement at 12 weeks, again, there's an advantage for the FlexiTouch system over the biocompression system, EO651. So this clearly shows that the advanced pneumatic compression device is very successful, and these are in patients, obviously, who have breast cancer-related lymphedema, a more homogeneous population. When you look at ancillary measures, there is a big focus on skin care, which is important for preventing infection, where 3 out of 4 of the CPGs provided extensive discussion. All 4 talked about exercise, and that's particularly focused on patients with breast cancer-related lymphedema, and none felt that drugs were indicated because of the lack of evidence. When it comes around to surgery, as you know, we divided them into 2 types: extirpative surgical reduction by excision of tissue, debulking, which is an open operation, or liposuction. And finally, lymphatic reconstruction, lymphovenous anastomoses. When you look at the guidelines, both the LEDF and AVS at least discussed indications for surgery. The Northern Ireland guidelines said there is no indication for surgery. And then the Japanese lymphedema guideline said there's small and limited natures of studies restricts any conclusive evidence. By contrast, as opposed to the 3, which were limited by the data the references, the AVF guidelines had extensive discussion of about 10 pages on surgery with a 1C recommendation. So my question, rather than putting it at the beginning, what does the audience feel is the major flaw with current lymphedema guidelines? Is it lack of discussion of various treatment options, outdated literature supporting the evidence, a problem since it's conducted by societies with potential for bias, or do these overemphasize the role of surgery? And I guess you can vote now.
Yes.
Yep, 61% got the correct answer. Excuse me. Yeah, got the right answer. Outdated literature supporting the evidence so you all get an A. So in conclusion, this analysis showed that there's a limited number of guidelines. The majority rely on outdated data, and they're of low overall quality. There's a companion paper that we wrote that actually does an analysis of the quality of these guidelines and shows that they're of low quality. So our conclusion, just like it was for when we initiated the venous ulcer guidelines, it's imperative for our vascular societies to develop contemporary, high-quality, evidence-based guidelines for lymphedema.
Thank you, Tom. There's a question on why was the consensus of the International Society of Lymphology not taken into consideration?
I can't answer that, but it may have the fact that that particular paper had not permeated the lymphedema world at the time they did these guidelines. Remember, the guidelines, 3 of them were, the latest reference was 2007. So I think that's the reason.
So how often do clinical practice guidelines on any disease process or usually get updated? For example, like the AVF was done last in the handbook in 2017. Is there typically a time?
That's an excellent question. First of all, the AVF guideline was part of a book, and it wasn't, if you will, a standard guideline. But they recommend that they be reevaluated no less than 3 years. And because most systematic reviews, which form the basis for many of these guidelines, are outdated by 2 years. And then a method of analysis, the AGREE analysis, really feels that the guideline should contain as a statement, when initially written, when they plan to revise it. So the short answer is certainly should be considered at 3 years.
Now, I mean, do you think there's enough data or publications out there to I know AVLS is working on guidelines for lymphedema. AVF has been entertaining the thought about doing the same. They're actually in the process as well. But do you think there's enough data in the literature
Yes.
to put together another?
I actually did a systematic review focusing on randomized controlled trials for the treatment of lymphedema. And there's about 15 randomized controlled trials out there. I think we they may be small, like the Fife trial, but they should form the basis for providing some evidence to put forth recommendations.
And anything else other than randomized studies? I know we're working on, as a group, to put together a Delphi consensus based on expert opinion and current practices, but is that as valuable, or does it have value?
I think it's of great value, and I also think that you have to look beyond randomized controlled trials, because as we know, they tend sometimes not to deal with real world situations. And in the paper that you're going to present, representing an analysis of big data, that has powerful evidentiary strength. So I don't think you should be handicapped by the fact that there's not an oodle of randomized controlled trials.
Okay. Steve, any comments or questions?
Oh, no, how can you add anything to what Tom said? No.
Tom left you speechless again.
Yeah, he did. Yeah.
And I wasn't banging you. You wrote a very good chapter in the AVF guidelines.
Oh, no, I was wondering how I missed that. I'll have to go back.
But unfortunately, there was no systematic review performed with it. So
There was a question about lymphedema surgery and the role. I'm not the best person to answer that question. I know there's, especially the last 2-3 years, increasing interest and number of procedures being done by plastic surgeons and microsurgery. But I'm not, and with pretty decent results, but again, this is in specialized centers.
yeah, let me take a crack at that. There's a paradox here. The reconstructive venous surgery, lymphovenous anastomoses, or lymphatic to lymphatic, are best done in early stage lymphedema patients, some actually done prophylactically, whereas reduction surgery, liposuction, is usually done in patients with very heavy, boggy limbs, which limit them from getting around. Even though you do the liposuction, according to most plastic surgeons who do a lot of this, these patients are wedded to using pneumatic compression for the rest of their life to maintain the reduced size of the limb.
Yeah, I think the biggest problem with that, not probably, is just like Tony's limitation. You don't have many centers that offer these surgeries. Very few. I'm lucky at Ohio State, we do have that. So.
Were there any European guidelines included in this, Tom?
Yeah, the lymphedema forum guidelines are composed of some people from Europe. As I said, we've got Japan, and we've got the American Venous Forum.
Okay. All right. Should we move along?
Yeah.
So I'm going to take a crack at this last paper, who Dr. O'Donnell is actually one of the authors again, and it's on, let me just share my screen. Health economic benefits of pneumatic compression. And this is mostly in patients with, as you'll see in phlebital lymphedema. So just a poll question here. Do you use IPC in patients with phlebital lymphedema? And let me, since I'm doing both here, I got to launch this. So this is for the audience, obviously. So pretty high number, 80% of the audience here uses IPC for patients with phlebital lymphedema. And the next question is, in patients with phlebital lymphedema, treatment of their venous disease results in complete relief of swelling in what percentage of patients? 10%, 30%, 60, or 80? Okay, so if you look at most of the literature here, this is actually a paper by Neglen and Raju back in 2007. And this was almost 1,000 patients that underwent either iliac vein stenting and with or without treatment of superficial disease at the same time. And you can see here, in the complete relief arm, only about 30% of patients at 5 years had complete relief of their swelling. So again, up to the point that I made earlier, in patients with long-standing phlebital lymphedema, they get damage of the lymphatic system, which is trying to compensate, but over time, that compensation is no longer capable to happen, and they end up with persistent swelling even after fixing their underlying venous disease. So we'll start off with this paper here, and the methodology of it basically was de-identified HIPAA-compliant commercial administrative claims database from Blue Health Intelligence between the years of 2012 to 2016. And patients with a diagnosis of lymphedema were first identified using ICD-9 and 10 codes. And the criteria to be part of this review basically was patients had to have health benefits for at least 12 months prior to the diagnosis and at least 6 months after the index event. They also had to have a diagnosis of CVI, or chronic venous insufficiency, within 12-month period prior to their index event to kind of give them the diagnosis of phlebital lymphedema. And finally, they need to have received treatment, or at least one claim of conservative therapy. So all the patients in this group had either MLD or lymphatic related physical therapy or occupational therapy. The data that was collected included demographic and socioeconomic characteristics, as well as baseline comorbid conditions were collected, as you can see in this table here. The evaluation of multiple compression modalities and their impact was looked at, including conservative therapy, the use of FlexiTouch, and simple pneumatic compression devices, and finally, all other advanced pneumatic compression devices were looked at. The patients were then subdivided based on therapeutic intervention that was prescribed. And the outcomes that were collected included the number of cellulitis infections, the absolute and mean number of per patient hospitalizations, outpatient visits, as well as PT and OT visits. And then they looked at medical resource utilization and total cost, which was calculated by a patient per patient per year. And these were only costs associated with the management of the fluid lymphedema and excluded any prescriptions, drug prescriptions, and medical equipment, as well as the cost, the upfront cost of any type of device that was prescribed. So as you can see here, the whole total group that had a diagnosis of lymphedema was about 80,000. When you looked at patients who had at least the health benefits of 12 months prior and 6 months later, that broke it down to about 27,000 patients. Then looking at those who had a diagnosis of CVI at least 12 months prior, reduced it to about 8,600 patients. And then finally, those who had at least one claim for treatment of their lymphedema, we ended up with just over 1,000 patients. Now, they were subdivided into these comparison groups, and you can see there was 87 patients in the FlexiTouch arm, about 860 patients in the conservative therapy arm, and 34 in the simple pneumatic compression device, and about 84 in the other advanced compression device arm. So one of the reasons, talking to Tom, that this number in the simple pneumatic compression device is because with this type of insurance, they can proceed directly to advanced pump compared to a simple pump. So you can see there's between the FlexiTouch and the arm 3, there was 160 patients compared to a simple.
One other thing is that from this 1,065, a process called propensity matching was carried out so you could match the demographics and other medical risks of the comparative groups, making them equal. So that reduces it even further to end up with this number.
Thanks, Tom. So here's a table basically looking at some of the demographics. You can see the mean age was in the 50s. Over 60% of the patients in most of the arms were females. All these patients, like I said, had to have a diagnosis of CVI, but interestingly, you can see a very high number of these patients had a diagnosis of venous leg ulcer. When you look at the comparison groups that we're going to go through now, group 1 looked at patients who had conservative therapy versus the FlexiTouch. Group 2 was FlexiTouch versus simple. And group 3 was FlexiTouch versus other advanced pumps. And of note, all of these patients that also had a pneumatic compression pump also had to have conservative therapy as part of their billing. Now, looking at resource utilization in the first group, which compared conservative versus conservative FlexiTouch. Interesting, you can see here the patient, not interesting, but the patients that had a conservative therapy alone had significant higher utilization of hospitalization compared to those who had a Flexi, and outpatient utilization of PT and OT was significantly higher. When you look at the comparison group arm 2, you can see there were the 34 patients that we showed earlier, and then with the propensity score matching, the Flexi group, which was 86, was reduced down to 23. And with these small numbers, despite the fact that almost double cellulitis reported incidents in the Flexi group, that difference was not significant because, again, these numbers in these comparative groups was very small. In the third arm, which was the Flexi compared to the other advanced pumps, the cellulitis here is half compared to the advanced pump, although the utilization of hospitalization was no different. Now, when you look at cost overall, in the first comparison group, comparing Flexi to conservative, there was a 70% reduction in per patient per year cost, 12,000 versus 4,000 almost. In the Flexi versus simple, an 85% reduction in per patient per year cost overall. And when you look at the final group, Flexi versus other advanced pumps, there was a little bit over 50% reduction in total cost. So significant reduction in cost in each of these groups. Again, with comparison group 3, small numbers, so it's really hard to tell. You know, one patient alone in either one of these groups could have made a difference. Similar to before, you can see here where we said the cellulitis was double, but again, just a couple of patients more in one group versus the other can result in a significant difference, in the difference in the statistics, in the percentages, but not necessarily in the p-value. So when looking at this paper, my criticisms as far as limitations, and some of these are also mentioned in the paper by the authors, is that this is a group of patients who have private insurance, and really some of this data may not be generalized to the Medicare population or the uninsured population. These are claim data, and obviously there's limitations when you look at these big data as far as misdiagnosis, inaccurate coding. So obviously always keep that in mind when reviewing publications related to claims data. As Tom mentioned, this is in order to match and try to create a more comparative arms when you compare groups. There was propensity score matching, and this results sometimes, like in comparison group 2, in small number of patients as you're trying to match the control arm to the treatment arm. This study was focused on use of pneumatic compression devices, so really we have no data on utilization of compression garment and bandages and compliance with these. And the next point was that in this, we're looking at, one of the arms was comparing FlexiTouch to conservative, and then Flexi to other devices, but there was no comparison of the other devices to conservative therapy alone reported. The data, there's really no data on compliance overall between the two different type of devices in comparison of this. No reports on ulcer healing. That would be nice to see if there was any difference in ulcer healing in the different arms. And finally, I think the lymphedema severity is not available. So we really couldn't do any propensity score matching to make sure you're comparing apples to apples as far as different stages of lymphedema in the different treatment arms. So that's kind of my criticisms or what I thought were limitations of this study. But overall, I think it was pretty good as far as showing that using pneumatic compression, especially with FlexiTouch, there is a reduction in total cost, and we can talk about in the discussion as far as what this can be attributed to. Okay. And since I have a co-author, or I have the author here, some of these questions, I'm sure he can help out with answering. As I'm looking through, Steve, do you have any comments or?
Oh, I was just curious. I guess, was there any way of you said 90% of these had venous limb ulcers. Could you tell if they were C5s or C6s?
No, based on the ICDs that were used, there was either an active ulcer or a healed ulcer. But it was no breakdown as far as if the patient had an ulcer active. And also, like I mentioned, no breakdown as far as healing rates, because again, this is claims data, so it wasn't really easy to get that information.
On a side note, Dr. Gasparis, did you use pumps in the setting of active venous limb ulcers?
Yeah, I mean, it depends. You know, some patients, as we know, have venous ulcers with no swelling or edema or anything. But those that do have fleeble lymphedema, I do put them in a pneumatic compression pump, and I'll do it even on top of their compression bandages that they have. So I don't necessarily wait for them to heal or have them remove their Una boot or whatever to use a pump. How about you, Tom?
No, I think you're exactly right. It's critical, however, that you cover the wound. You really have to cover it, because sometimes you can get shear force from any pneumatic compression device. I was interested in the large number of people who use pneumatic compression for patients with fleeble lymphedema. I would suggest that they may be using a great proportion of simple pneumatic compression devices with an eye towards reducing venous hypertension, rather than using a device to promote lymphatic flow. Because venous hypertension is the big target of our surgery, and everybody believes that's the underlying pathophysiology. But as you point out, lymphatic dysfunction is equally important, and you need to treat that with pneumatic compression.
Yeah, I mean, I have really also moved into the practice, especially with patients after intervention. You know, unfortunately, a lot of patients go to the interventionalist, get either an ablation or a venous stenting, and you know, sometimes, you know, most of the times their symptoms improve, but their signs of swelling or their swelling does not get better, like I mentioned earlier. And in that group of patients specifically, you know, rather than just telling them, I'm sorry, this is, you know, I told you from the beginning, you got about a 50–40% chance of improving your swelling, you know, rather than just sending them out with just a stocking, you know, continuing treatment with pneumatic compression is very beneficial, rather than letting their fleeble lymphedema continue to cause potential cellulitis or anything like that.
I think that slide you showed by Raju was a very compelling slide, very compelling.
Yeah, and I echo what you were saying, Tom, about just the lymphatic part. I really am becoming interested in just the lymphatics within the skin. Because you think about, I mean, why is the cellulitis being reduced? It's got to be the reduction in dermal lymphatic hypertension. I harken back to Stan Roxon had an article, an editorial entitled "Lymphedema is a Disease of the Skin." I think that's the area where the reduction in cellulitis is occurring, and you can affect change with a pneumatic pump, and you've got the good data that Tony just published or discussed with the FlexiTouch.
Well, we did some NERFLY studies in patients with venous ulcers and showed the promotion of movement of lymph by the FlexiTouch machine. Basically, also, that lymph pools there and it becomes a beautiful bacterial culture. They can breed within that, so mobilizing that lymph out of that area is very important.
Because it really is interesting. I'm becoming a firm believer in this, because I see so many patients that we administer pumps to, and their swelling doesn't necessarily get that much better, but to a T, they are telling me they haven't had, and it's reinforcing, because they say, well, you know, I haven't had an episode of cellulitis since I started using that. So there really is something to this skin decongestion.
Well, we have data not shown tonight from that same group of BHI patients that shows that's exactly correct.
Are all pneumatic compression devices for fleeble lymphedema equal? Tom?
No, they're not. I mean, mechanistically, the simple pneumatic compression device is not adjustable as opposed to an advanced pneumatic compression device. The number of cells available are different. The pressure cycle is different in even some of the advanced pneumatic compression devices. Not making it commercial, but the FlexiTouch tries to simulate manual lymphatic drainage and stimulate movement of lymph through the lymphatic vessels as opposed to a high pressure squeeze and hold that tries to mash it up through the interstitial space or the lymphatics. So they're not all the same.
And I think the randomized study you mentioned earlier comparing Flexi, they had a lower edema and volume reduction, a higher reduction in volume compared to the other pumps.
Right.
And in this paper showing some, again, this is a claims data, it's not a randomized study, but, some suggestion that there is a reduction in cost potentially from lower incidence of cellulitis and lower hospitalization.
Tony, did you see there's questions up here? There's one about, what is your opinion about the role of ICG fluoroscopy to indicate surgery for lymphedema? At least at our institution, our lymphatic surgeons, they use it all the time on every patient they're examining for a surgical option. The one thing I point out about ICG, and I think Tom would probably recognize this, is it's interesting when you see these articles in the literature, they show these beautiful images of the deep lymphatics, and you really don't see those with the commercially available ICG probes. You just see superficial and that's it. So it's not what you're seeing in these articles.
Yeah.
Well, that's because there's two types of techniques. One is the one that you referred to, which is really aimed at superficial, and the other is Rasmussen and Ivasevic's technique, where you're able to see both the superficial and deep.
But that's not commercially available, though, I don't think.
It is now.
When did it become available? That's interesting.
Well, Eva has formed a company, and now it'll become commercially available.
Obviously, just even if you look at the superficials, it answers the question: is that patient a candidate for lymphovenous bypass? So that's why they're using it, just for that reason.
So one of the questions: morbid obesity, would you do an ablation for reflux? For morbid obese patients, unless they have really advanced CVI like venous ulcer, I typically do not offer them a treatment of superficial reflux. Number one, I think the failure, especially with morbidly obese, the failure rate of intervention is pretty higher than other patients, and more importantly, they have a central venous obstruction problem, not a superficial problem. This is an interesting question. I'm not sure the answer is. In India, for elephantiasis, heat therapy in specially designed ovens is practiced in some centers. Please comment. Steve, you have any?
The largest center at my institution of using heat ovens, and no, what can you say? I can't comment on it. I don't know.
This is for filariasis?
I guess for lymphedema.
Yeah.
Well, that's the most frequent cause worldwide.
Yeah.
Not in the United States. I don't know. Maybe they're killing the lager. I don't know.
I don't know.
I'm not sure. How about exercises in pool, like water therapy for lymphedema patients? Actually, we just had our Venous Symposium this past weekend, and one of our speakers from Italy, Dimitris Kondathanasis, he gave a great talk on the effect of water on reflux. And actually, they did a venous reflux study outside the water. Patients had severe reflux over 5 seconds, and they repeated the ultrasound with the patient in the pool and had no reflux.
Well, if you look at, sorry, go ahead, Steve.
Oh, no, I was just going to say, anecdotally, it is a wonderful modality for reducing leg swelling. I hear it time and time again from our pool walkers.
Well, back in the 1950s, Conrad Jobst, when he developed pneumatic compression machine and compression, that's where he got the idea, is being in a pool, the hydrostatic pressure reduces the swelling.
But I don't think there's any studies looking at lymphatic flow and the effect of water for that. Has
No.
it? Interesting. Well, I mean, if you reduce the venous hypertension, it should improve your lymphatic flow.
Yeah.
And that's why
It should improve the dermal lymphatics, I would think.
yeah. Can you foresee a point where ICG can be used? Oh, can you foresee a point where ICG will be used for reimbursement as a diagnostic tool for lymphedema? Tom?
Potentially.
Yeah.
Yeah, especially if you can see that you got to be able to see the deep lymphatics, but I guess that's taken care of now with the new device. So
I think it will be like many reimbursement schemes. It will be for selected patients that satisfy certain requirements. It won't be universally.
Since you have some people that are doing lymphedema surgery, what's in your experience that you've seen, Steve, what's the best treatment modality from a surgical perspective?
At least now, this is all anecdote. My surgeon probably wouldn't like me for saying this. I haven't seen a lot of improvement in lower extremity lymphedema with lymphovenous bypass. I just don't see it. But with the vascularized lymph node transplants, I've definitely seen some impressive improvement. There's no cure, and the fatty deposition remains, but they certainly improve. But then again, we're lucky in the sense that we have a surgeon that's very aggressive, and in the patients that Tom was referencing that have elephantiasis and just horrible disabling skin changes, he'll do a modified Charles procedure with impressive results, because you get to a point where there's nothing else you can do for these patients. And so I'd say those are my two go-tos. If it's a late stage 3, it's going to be a reduction procedure, and the venous or the vascular lymph node transplant for a lot of the stage 2s. And then liposuction too. He's selectively doing more liposuctions in the stage 2s with good results as well.
So someone made a comment based on my earlier comment about using pneumatic compression devices in patients who have persistent swelling after intervention. The comment is basically, I believe that PCP will not completely decrease swelling in patients with febrile lymphedema after venous ablations due to incompetent lymphatic system. So I'm not saying pneumatic compression alone. I think these patients, obviously, they have persistent swelling, and getting them in,
Compression stockings.
Compression stockings is definitely part of the therapy. But again, this is not, patients are not as compliant with pneumatic, with compression stockings. And if they have significant leg swelling, the combination of either getting them in MLD therapy for the acute phase, if they get worse, and then some type of maintenance therapy, because this is a chronic problem, and they need to have, a chronic therapy, whether it's a compression alone or in combination with pneumatic compression.
Yeah, and I can't underscore I'm sorry, Tom.
No, go ahead, Steve.
I can't underscore the importance of weight loss, because when you're doing ablations and not that you would, Dr. Gasparis, but BMI of 45 and you're ablating them, or even you can put an iliac vein stent in, until they lose significant weight, I just don't see dramatic improvement.
Correct.
I was going to make the point that skin care and early treatment of infections is critical, because once you get an infection, it burns the lymphatic collaterals, just totally destroys them. So you really got to be assiduous in preventing infection.
So Dr. Dean, I'm going to be calling you Dr. Dean from now on.
Okay, good. Thank you.
I feel like that's the reason you keep on calling me Dr. Gasparis. What percentage of lymphatic leg drainage do you think is dermal drainage as opposed to perivenous interstitial? I'm not sure the answer to that.
Yeah, I don't know.
As they say at a Trump press conference, I'll get back to you on that one.
Here, did you see that one question, Tony? Why do you propose any chronic, or why do you propose any chronic edema as lymphedema? Clinically, they have very different aspects. So that's a loaded question. I would certainly argue that any chronic edema is clearly lymphatic failure. I don't know how you could argue with that, but as far as how are we defining lymphedema, I assume you're saying they have to have associated inflammatory and fibro fatty changes to truly fulfill the definition of lymphedema. I think that makes sense, but I guess, yeah, the question becomes if you have somebody that has transient edema with heart failure versus somebody that had lymph node dissection, those are two different processes. But any chronic edema, it represents lymphatic failure. If the lymphatics are working correctly, you wouldn't have chronic edema. And we can argue on how you define lymphedema based on what I previously said. I mean, what do you think, Tom?
I agree. Influenced by Roxon's paper that all edema of lung-staining nature is lymphatic in some way.
In some way, exactly. It's some kind of failure.
I mean, if you look at any type of failure with any organ, right? It's inability to compensate, whether it's the heart, the kidneys, the venous system. This is an interesting question. What do you recommend for increasing patient compliance with lymphedema pumps?
Oh, boy, that is a tough one. I try to emphasize the positive things that have happened, especially that reduction in cellulitis, and I quote those papers a lot to the patients. I use this at 75, 80% reduction, and that's one thing I try to do, and it keeps you out of the hospital, et cetera. That's a tough one. Because we all know that you order a pump and it ends up in the closet when you see them back in the clinic.
So, I mean, there's some, Tom, did you have a comment on that?
No, I'll let you comment.
I was going to say there's, I know there's certain things that are happening to try to increase compliance, whether it's making these pumps a little bit smarter and reporting compliance to your, referring for your physician as far as time used and also providing positive feedback to patients as far as looking at volume reduction in their leg through the wearable device.
Exactly.
So I think those are things that potentially, the same thing with the compression stockings. There's some data looking at smart compression stockings, that would give you feedback, both as far as compliance with wearing it and size reduction or volume reduction. But those, I think, would be definitely helpful. Just like with your steps when you're wearing your iPhone, your wearable Apple device. Yeah. All right. The questions keep on going, but I think, should we continue? It's up to you guys. I think
if we have answers, I think that'd be okay. But
yeah, we'll type some of these answers in. Some of them, I'm sure, Flexi, the Tactile people can get. There's some questions on cost, which I'll leave up to Tactile to reach out to you. And I probably close it off now, and we're almost an hour and a half into this. So I want to thank, first of all, Tactile for putting this together. Obviously, this is a first endeavor at trying to do a little bit more reviewing of the literature and try to get more evidence-based out there, information to the people that get on these webinars. I want to thank Tom and Dr. Dean, my co-panelists here, and putting this great presentation and making it kind of interactive for everybody. Also, I want to thank the audience. Over 140 people were at the max here. Wow. And for being interactive and asking questions, very good questions. And finally, I want to close off with the upcoming educational events that Tactile is putting together. On August 13, navigating swelling in a primary care setting. This is mostly geared to primary care physicians, but We're going to go through a couple of different things, including algorithms and diagnosing lymphedema. And then on August 18th, phlebital lymphedema overview and treatment with Susan Ellenson. And then in September, there's a head and neck on September 24th on radiation fibrosis and lymphedema. TactileMedical.com/learning for more information and upcoming events. And thank you everybody for participating.